With you. I'm Nice to meet you all. I'm Nayeli Borjas. I am a fifth year medical student here in Peru. My university is San Martín de Porres. I'm really glad to be here, and I've been invited by Marco Málaga. He was the founder of HEIN, which is the Grupo Estudiantil de Investigación en Neurociencias, which is a group formed by medical students which want to learn how to investigate, want to learn how to teach others how to investigate. And well, finally, our main goal is to produce papers, produce new information about neuroscience. And well, we have two subjects, like general subjects, neurology and neurosurgery. And well, I hope that one day I will be a neurosurgeon. So thank you.
Yay, Nayeli, thank you so much for being here. Everybody, welcome. This is Global VMR. We had the pleasure of hearing Nayeli introduce herself. Today is going to be a little bit different. As you can see, we are going to have a global Neuro VMR with friends from Peru. We hope that in these sessions on Saturday, we get to know a little bit more about our colleagues in the rest of the world, and we get to see some differences in clinical reasoning that are affected by culture and geography and language and all the good stuff. So today we have friends from Peru that are interested in neurology, just as Nayeli said. She's doing great research in neurology in Peru, and we're going to get to hear a little bit more about her and her research team at the end. At the beginning, sort of as an appetizer, we're going to have a case that Erin and Chiara are going to be discussing. Erin, do you want to go ahead and introduce yourself?
Sure. Thanks, Maria, for organizing these global VMRs. They're always exciting, and particularly exciting when we have neurology. Did one several months ago with colleagues from Zambia and East Africa, and learned both about the case and then how the case was approached in an environment with very different epidemiology and very different resources to evaluate and treat a case than we're used to, and that enhances our clinical reasoning and also allows us to get to meet people from all over the world who are doing similar work to as we are. So we're very happy to have our colleagues from Peru with us today, and including Chiara and Nayeli. So as Maria said, we'll have Chiara, maybe you can introduce yourself also, since you're going to be presenting the case, and also from Peru, and then hopefully Marco, who prepared the case, will get to join us as well. I think all from the same medical school in Peru, if I'm not mistaken. So go ahead, Chiara.
Yeah, hi friends. It's very nice to see you all. I'm glad that in this opportunity we have HEIN. This is a very well-known neurology science group where they perform many research projects. I've been able to work in some research projects with Marco, and well, some other with the past. I remember past leader with, he was Diego, and Aaron also he was named Aaron. So yeah, it's nice to see you all. I'm a CP Solver team member, and I will be presenting the case. Actually, Marco is supposed to be presenting the case, but he will join us a little bit later. So I will start the case presentation. Okay, just give me the time to start. Okay, so the chief complaint is headache.
So the chief complaint is headache. So we'll do things a little differently today. As Maria mentioned, we won't have the discussant, so we have time. So Chiara and I will just talk back and forth. And of course, if anyone else from colleagues in Peru want to talk about their approach, please feel free to unmute and join, or in the chat, say that you want to tell us something, or of course, feel free to ask questions. So we've discussed headache many times on this VMR, so maybe we'll just be a little bit brief in our approach, so we can get into more of the case and understand how the approach might be different, both epidemiologically and in terms of available resources to Chiara, Marco, and their colleagues when evaluating a patient with headache. So in general, when we think about headache, right, Headache is pain in the head, right? And so the way I like to think about the potential causes are things in the head, things of the head and neck, and systemic causes of headache. We've all had headaches before from various causes. And so we can think of those causes in these three categories: inside the head and neck, of the head and neck, or systemic causes of headache. So inside the head, right, we have the brain, but we can't also forget the arteries, veins, meninges, all of the things that could develop some type of condition that would cause pain. And then when I say of the head, we think of many other causes of headache that can be related to problems with the eyes, nose, sinuses, dental problems. And we have to include the neck because the neck is connected to the head, and sometimes neck pain and headache go together, or neck pain can be referred to the head. And within the neck, of course, we have the spine. We also have the arteries. So you could have carotid or vertebral dissection, for example, causing a headache, et cetera. And then we get into systemic causes, and we all know when we have a viral illness, there's often a headache associated with that. We know when we get the COVID vaccine, right, that there's a headache associated with that. And I always wonder, what is this headache? I'm experiencing headache. Is this from just cytokines, or is there some mild irritation of my meninges? I don't know why we get headache with these things, but those are the three broad categories to think about in terms of underlying causes anatomically. And then we also want to try to tease apart in the history, is this what we refer to as a primary headache, or is this what we refer to as a secondary headache? And the secondary headaches are causes that would fall into the categories that we just mentioned, right? So causes of headache that we can identify, that there's some cause, some etiology that we can pinpoint, such as something in the brain, a brain tumor, a brain abscess, something in the meninges, meningeal tumor like a meningioma, meningitis, something in the arteries, vasculopathy, vasculitis, something in the veins, venous sinus thrombosis, something in the eyes, nose, neck. So we're trying to tease apart from the history. Is this a problem in the head, of the head and neck, or systemic? Those are all of our secondary causes. And then we want to understand, if there are no secondary causes, is this a primary headache disorder? Things like tension headache, migraine, cluster headache, which falls under a broader category of the trigeminal autonomic cephalgias, which include things like SUNCT and SUNA and paroxysmal hemicrania continue, a long list of primary headache disorders. And those are important to categorize by history because they have they behave differently and they're treated differently in terms of both acute abortive medications and preventive medications. So the key to the history really is first trying to divide in this branch point of, is this a primary headache or a secondary headache, right? So that we want to look for what we call red flags. And those red flags involve clues that there could be a secondary cause. So things like a progressive headache might make you think of a progressive mass. Headaches that are worse first thing in the morning are concerning, that the intracranial pressure is elevated, or headaches that are worse when bending down, when coughing, when sneezing, et cetera, it suggests elevated intracranial pressure. So there are features of the headache that can give you clues as to that there's a secondary cause. So we mentioned provoking factors. A thunderclap headache, right, would make you concerned for some type of vascular etiology like subarachnoid hemorrhage or reversible cerebral vasoconstriction syndrome. And then we think of, so those are aspects of the headache itself that would be red flags. And then there are aspects of the context that would be red flags. Headache and a fever might make you think of meningitis. Headache and a seizure, a headache and a focal deficit might make you think of a focal lesion. Headache and a patient with cancer, right, might make you think of metastases. Headache and a patient who's immunocompromised might make you think of some type of infectious process, right? And if we can sort of go down our list and assure ourselves that there are no red flags, then we want to ask questions that will help characterize, does this sound more like tension, like migraine, or one of the rarer primary headache disorders? So as I'm listening to the history, I'm looking for that description of the headache, how it behaves. Is it episodic, continuous, progressive? I'm looking for things that could be provoking it. I'm looking for other contexts in the history in terms of other features, fever, seizure, focal deficits that are accompany the headache or are progressive, including the headache. So those are some of the things on my mind when I first hear headache, and the types of things that I'll be listening for in the history. So can we hear a little more, Chiara, than this one word and see where we go? And then maybe that'll allow us to also start thinking a little bit more about our context of the patient being in Peru.
We would love to, but we have Marco here, so he can continue now.
Oh, great. Marco, do you want to introduce yourself? We're glad to see you.
Hi, yeah, I'm so sorry for the delay. I don't know if Maria told you, but yeah, I'm traveling to Kansas and I'm literally in a road stop in the border near Wichita. But I got Wi-Fi and I'm set up and everything's great here. Yeah, yeah. Okay, so would you like me to continue with the history of presenting illness?
Please.
Okay. So this is a pleasant 32-year-old male that has a 3-month history of bilateral pulsatile occipital headache. It's continuous, it's of moderate intensity, and it is associated with nausea and occasional emesis. I'll just give you one more aliquot before to continue. It's he has visited the emergency department twice. Our non-contrast head CT was done and it was non-diagnostic. He was then followed up as an outpatient with symptomatic treatment without improvement, and he now describes decreased bilateral visual acuity and generalized weakness.
And you might have said Marco, but I didn't see it end up on the page, and so I might have missed it. What's the age of the patient?
32-year-old male.
32-year-old, yeah, 32-year-old
Yes.
male. So the headaches are episodic, and is the patient normal between the headaches?
They are continuous. They have episodes where the headaches are of increased intensity, but they are continuous.
Continuous. And the patient before this 3-month period never had any history of headache before?
Never had any history of headaches before, yes.
Okay, so let me ask you, Marco, when you were seeing this patient now and hearing this history, what were you, I know you know the final diagnosis, but going back in time, what were you thinking at this stage in terms of your differential diagnosis based on this history?
Well, it sounds a little bit like cheating because I know the final diagnosis.
Go back in time, yeah, where you were thinking when you first.
But back in time, I mean, because of how common it is, I first just because of the pulsatile nature, and even if he describes them continuous, they have episodes where it increases. I would just say that it sounds a little bit like migraine because of nausea and headaches. So that's what I would initially think, but and that's also supported by the fact that the CT head scan is non-diagnostic and there is no intracranial mass or anything. However, I do think that one has to keep in the differentials order disorders like hypertensive endocranial disorders because of the fact that the headache is continuous, and maybe those episodes of increased intensity are related to waking up, for example, or changes in position that may, and also there's no description of like projectile vomiting, but maybe the emesis is associated with that. So I would just keep that also in mind. And yes, that would be my first like two cents on that.
Yeah, excellent. I agree with you. When you first hear this is a relatively young person with a pulsatile, occipital, episodic headache, your mind jumps to migraine, right? It seems to be checking off the aspects of the criteria of migraine. There's some nausea and vomiting with it. So lots of features here to say migraine. But as you said, the fact that there's a continuous headache in the background would be a little bit atypical. Most patients have episodic migraine, though there is a diagnosis called chronic migraine, in which patients have more continuous migrainous type headache. If you're interested in headaches, so you can look up the International Classification of Headache Disorders. People have heard me describe this as like the DSM of headaches, or the taxonomy of flowering plants of headache disorders. There's every headache disorder. People get together in a committee and decide, how do we define migraine? How do we define tension? And there are countless headache disorders. Nummular headache comes from the word for the size of a coin-shaped headache. There's tons of headaches in there that people have identified and seen and sort of identified these patterns. So it's not surprising that people would see this patient and think young, healthy, does this patient just have migraines? And you would ask yourself then, are there any red flags that would require me to get some type of image? And I think Marco identified one of these, that there is a continuous headache and progression in these episodes. And the other is, it's quite possible this patient has new onset migraines and there's some continuous headache in the background because the patient has untreated migraines and sort of always feels they either have a migraine or they're recovering from a migraine and they never quite get back to normal. And yet, this is a young person who hasn't had any brain imaging, who's having severe headaches. You would want to reassure yourself, at least even if your clinical suspicion was migraine, that you're not missing any type of brain lesion. And I think there's one more thing I was going to say. It slipped my mind as I was thinking through many things I could say. So I don't remember. Okay, it'll come back to me at some point. So a CT was obtained, and maybe we'll just pause there for a second, Marco. And in the hospital you were working in when you saw this patient, how easy is it to get a CT scan?
Well, in general in Peru, it is not AC at all. But in this particular hospital, this is a national referral center. So CT scans are relatively easy, not US easy. So it's not like, yeah, you go and you get one, but it will take around 3 or 4 hours, maybe 5, but it will be done in the same day. It's not like it's usually here. Usually in most hospitals, it will take like 3 or 4 days, but in here, but in this hospital, it's done in the same day.
Okay, so that's good. That's helpful to know, because one sort of clinical reasoning clue was with Marco told us he was doing a rotation in rural Peru and we heard this patient got a CT. It would tell us people were pretty worried about this patient, that they thought it was worth, right, the effort and time and probably cost to the patient and their family to get it, instead of saying, let's just see if this is migraine. Which reminds me of what I was going to say before, and that's the migraine is a syndrome, right? And you can have primary migraine, which is what most people have, but you can have secondary migraine, meaning there is a lesion in the brain that is causing the phenomenology of migraine. I have a very memorable patient who is driving and saw these bright flashing lights moving across his vision, sounds just like migraine, right? And then he had a bad headache after it, and he came to the emergency room, and he was older, so he got an MRI, and the story was picture perfect for migraine. And he had a small embolic occipital stroke, and something about the area where he had had that stroke was provoking the phenomenology of migraine. And so there I was on round saying, oh, this is an interesting example of secondary migraine. And the red flag was that he's older and he's never had one before. And then he kept telling us that the bright lights would come and flash and then sort of go away. And we said, yeah, you're having some migraines from your stroke. And then we went in to see him once and he just looked very surprised. And he said, something just happened, like I was electrocuted or something. And we said, oh, I don't know what happened to him. He looked at his monitor and he'd had an episode of bradycardia, and we put him on EEG, and those migrainous episodes were actually seizures. He was having occipital seizures from the stroke. And when you have seizures originating from the primary visual regions, they cause very elemental visual forms. Hallucination sort of sounds too elaborate, I guess. They're not people or animals or these things. It's just usually very basic shapes or bright lights, things that the primary visual cortex does, right? It sees brightness and line and shape and all of these things. So this patient had a secondary migraine from a stroke causing secondary seizures. So it was like a thing on top of a thing on top of a thing, but the patient looked like they were having migraine, which is kind of interesting. So, right, all that to say, I agree with Marco and his colleagues, right, that this could be a migraine, but he's a young person, he hasn't had it before. We better get a CT, and we know that if this was migraine, probably the case would be very short, and we wouldn't have too many more aliquots. So I guess the question would be then, we're concerned enough that we wanted to get imaging. CT is inexpensive, it's easy to get, it's quick to get, and in places where it's hard to get a CT, it's surely even harder to get an MRI. So a reasonable first pass to look for a mass or something like that. And yet, CT is obviously a lot less specific in what it can pick up. So this patient clearly doesn't have a big mass, a big hemorrhage, a big stroke, but may still have something that was not picked up on the CT. So what types of things could there be? Well, this has been going on for 3 months. So I guess one question would be, was there an abrupt onset, or has this sort of been gradually emerging over those 3 months? Hard to say. You probably either have a first headache or you don't, right? So it might be hard to pinpoint that something acute happened. This patient had some bleeding event or vasospastic event that then continues to recur. The bleeding we should have seen on the CT as a hyperdensity. If the patient is having intermittent vasospasm from the diagnosis reversible cerebral vasoconstriction syndrome, people were asking me questions about this on Twitter yesterday, so it was on my mind, right? You would need vascular imaging to see that. It can cause some convexal subarachnoid hemorrhage, meaning not the big starfish that you see on step 1 in the basal cisterns, but a little bit of blood just sort of in the sulci. It can cause stroke. It can be associated with press-like changes, but sometimes it's just the vascular narrowing. You'd need a CTA or an MRA or an angiogram to see that. Could this patient have venous sinus thrombosis? Again, there are sometimes clues on the CT. You can see hyperdensity over the sinus itself. If you have a CT with contrast, you can see the empty delta sign of the confluence of sinuses not filling. I think the hyperdensity in it over a sinus is called the cord sign. And again, but you could miss it if just the sinus is thrombosed and you don't have venous imaging. 3 months would be kind of a long time for that. Other things that could be CT negative and cause progressive with episodic headaches that we're not seeing anything on CT. Again, no tumor, no abscess, no hemorrhage, no other obvious pathology. Could this patient have idiopathic intracranial hypertension, also called pseudotumor cerebri, though we're moving away from that term, right? Because you explain it to the patient and then they hear the word tumor. And so I always say that before I say this, it has the word, I try to frame, it's going to sound frightening, but it shouldn't be. So usually just better to say IIH, but then that's a little harder for patients to understand. But pseudotumor, you have to emphasize the pseudo, or it can be frightening to patients, right? And this is a condition that can be idiopathic, usually more common in obese people, particularly obese women for some reason, but can be secondary to medications like tetracycline, can be secondary to endocrinopathies or endocrine-related medications. And for unclear reasons, idiopathic, right? We're unable to understand exactly why this is. The intracranial pressure goes up. So those are some things we could be seeing here in imaging negative progressive headaches over 3 months. So what happened next, Marco?
Okay, so I'll briefly give you his past medical history and his social history. Nothing is remarkable. He has no prior family history or medications or past medical history. But on review of symptoms, he did point out that he had 10-kilogram weight loss since the onset of symptoms. I'm not sure what's that in pounds, but so it's a 10-kilogram weight loss in the past 3 months. Additional to that, his health-related behavior, he does not smoke, he does not drink alcohol, there are no allergies. Social history is relevant. He lives with his wife and he works as a nurse assistant in a city in the highlands of Peru. On physical examination, vitals are normal and general exam is cardiopulmonary examination, abdominal examination is normal. Neurological examination is remarkable.
Sorry, let's just pause there for 1 second, Marco,
yes.
Before you give us so much additional information. And just think about for a moment what we'd be most interested in on the exam here based on some of the differential diagnoses. So we're worried that this patient could have something we said could be in the head, of the head, and neck, or systemic. Presumably it's a neuro VMR, so we're going to guess that unfortunately it's inside the head. And I forgot to finish going through my own schema, right? We talked about brain things. We're not seeing anything in the brain on CT and not hearing about weakness, numbness, tingling deficits, although we'll want to look for those on the exam, which is why I paused there. We talked about arteries and veins, and one structure that we wouldn't see very well on CT that's worth mentioning, right, is the meninges, right? So could this patient have not acute meningitis, right, for 3 months, bacterial meningitis? No one would survive that for 3 months without treatment. Could the patient have viral meningitis? You could survive that without treatment, but usually would not go for 3 months. Could this patient have a chronic meningitis? And we get into chronic meningitis. What are some of the differential diagnoses? Well, in terms of infections, we would think of tuberculosis, fungal infections, and parasitic infections that can cause meningitis. We can think of inflammatory meningitis. This can be associated with rheumatoid arthritis, sarcoidosis, IgG4 related disease. And we could think of people often don't think of, but there are medications that can cause meningitis. Heavy use of NSAIDs, Bactrim, IVIG can all cause meningitis. So I thought of our in the head things. I forgot to mention the meninges before. So I think key things we'll want to look for on the exam, right? One is to look for whether our concern for elevated intracranial pressure can be objectified on the exam, and we would do that by fundoscopy, looking for papilledema. We want to look for any focal deficits that could give us a clue that, hey, maybe there is something going on in the brain, just the CT wasn't granular enough to see it. Is there any meningismus? And then any stigmata of any systemic diseases that could give us a clue here. So, okay, so let's hear the exam and see where along this we are, and then maybe we'll pause there, Marco, and think about what would be in a general differential for the syndrome we think we have. Is it elevated intracranial pressure with nothing else, elevated intracranial pressure with focal deficits, elevated intracranial pressure with meningismus, systemic signs, et cetera. And then what things we might think about, particularly in the Peruvian context, and then what would be available for evaluation. Okay, so tell us what you found on exam. Sorry to interrupt you, and I love that the exam box has just been deleted to everything but neuro, my favorite.
Well, that was great. That was really good. I mean, you've already nailed one of the things, but I won't tell more. Okay, so yeah, and we'll talk about the whole, because I believe that social history is also relevant for how the whole case went. So the neuro examination, the patient is awake and he's oriented to person, but not to time or place. His initial cranial nerve exams revealed no findings, but on motor exam, there was generalized muscle weakness and 4/5 for distal extremities, more predominantly proximal, and 3/5, and reflexes, both in upper extremities and lower extremities. And for reflexes, there was hyperreflexia in the upper extremities, so 1+, and 0 in the lower extremities. There were no sensory alterations, but there was a bilateral positive leg raise test, so positive Lasigi, and a positive Kernig sign.
Okay.
Coordination showed no alterations, and gait assessment was not performed.
Okay, so we do have some symmetric weakness, but it's sort of generalized, and the question becomes sort of whether it's neurologic weakness or asthenia. So I think the most salient thing here is the Kernig sign, right? And Kernig and Brzezinski, we learn all these signs. Someone taught me once, K is for knee. That's the one that has to do with the knee, flexing the leg at the hip and then extending, and then Brzezinski is moving the head. There's a nice JAMA rational clinical exam series, Does My Patient Have Meningitis? Is the name of the article. And it finds that Kernig and Brzezinski sign are about 5% sensitive. So very specific, but very insensitive. I see Marco look surprised, and I look surprised also, but I think the reason for this, my guess is, I should say, I've seen a reasonable number of cases of meningitis in the US without Kernig or Brzezinski sign. And when I've spent time in Malawi and Haiti and other similar lower resource settings, I've seen lots of patients with very florid Kernig and Brzezinski signs. And I suspect that in the time of Kernig and Brzezinski, whenever they were doing their thing, I presume 100 years ago or more, that patients were presenting very late with meningitis when the meninges were floridly involved. And unfortunately, in resource limited settings, patients may feel, I have a fever and a headache, but I still have to work, still have to take care of my children, or healthcare is far away, or healthcare is expensive. And by the time they seek care, they're very ill with meningitis and they have the meningeal signs. Whereas in places where you can walk into the mall and go to urgent care and say you have a headache and they send you to the emergency room, and as Marco said, you might be scanned before you're even asked any questions in the United States, right? Then might be too early, and people are being treated early enough that they're not sick enough with meningitis to have these signs, and they've become very insensitive, meaning not many patients have them. But I think that's a bias probably to US studies would be my, or high resource setting studies would be my guess. And if you work in contexts where patients have less access to healthcare, you probably see these signs more in your patients with meningitis. So this patient has then meningitis. and this patient has 3 months of meningitis. So a chronic meningitis is a different differential than acute meningitis. So I'll ask Marco, you and your colleagues in Peru, but chronic meningitis plus TB endemic area, the first 12 things on my differential diagnosis would be TB, 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 TB. But of course, we wouldn't want to frame ourselves that way. And we would want to have an HIV test to know if this patient is HIV positive. They could still have TB meningitis, in fact, would be predisposed to having it. But then the floodgates would open to a longer differential of potential opportunistic infections. If the patient is HIV negative, of course, we want to be looking for TB. And you might say, but the patient doesn't have a cough and the patient doesn't have a fever. But I think it's about 50% of patients have neurologic manifestations of TB with no pulmonary manifestations, or have extra pulmonary with no pulmonary. And then, of course, the weight loss, if we add that all together, sure makes us think about TB, though, of course, there are other things. So let me ask you, Marco, and your colleagues at this stage, you're seeing a patient with chronic meningitis in Peru. You can tell me if my assessment of TB being 1 through 10 on the differential is similar to how you would think about it there. But what else is on your mind in terms of potential etiologies here? And I guess before, I'll just say our other favorite diagnosis from Peru, and we've had many cases presented from Peru by Valeria and Kira and Marco, is neurocysticercosis. And you might say, but doesn't that cause the cyst or the calcifications? I learned recently through a patient and through talking with some experts that you can get a chronic meningitis from neurocysticercosis without any lesions or cysts or anything like that. And a patient who I've been following who has had essentially cryptic meningitis with an abnormal CSF, who feels fine, just has this sort of finding on his scan and has mild headaches. And finally, someone told me you can send the cerebrospinal fluid to the NIH now in the US, and they have a very precise antigen test. And this patient had a very high neurocysticercosis antigen in the CSF, and for years has had meningitis. Anyway, it's a long story, which I won't get into since it's not from Peru, of why the patient presented so late. But I learned that neurocysticercosis, which commonly causes parenchymal lesions, can rarely, or maybe rarely figured out, can cause a chronic meningitis. So when we see chronic meningitis on the infectious side, TB, fungal infections, and Marco will have to educate us what else might be endemic there, and then parasitic infections or inflammatory causes. So what were you and your colleagues thinking at this stage, Marco, and how did you decide to work the patient up?
Okay, so up to this point, that you say the floodgates were opened. Of course, the first thing we thought was tuberculosis, because the patient comes from a very endemic area right in the north of Peru and right up in the highlands. He also has occupational exposure because he works as a nurse assistant. So that made a lot of sense. Then we thought about HIV as well, and we thought of brucellosis, because it's also endemic in that area. It's a very farmer area, and people are commonly exposed to unpasteurized milk and cheese, and so they usually, from goats and stuff, so they usually, brucellosis is like a common differential over there. Then we also thought about neurocysticercosis, which it's also a very endemic area of neurocysticercosis. There's a lot of pork meat and everyone eats that, so there were a lot of those. Then we also thought about autoimmune disorders that may cause meningitis. And we also suspected, because of the fact of those, some of the focal findings like the reflexia, that there may be a mass or a calcification or something that would be compressing the nerves. So our next step would be to order all of these serological tests and an MRI. And so, do you want to know what came up?
Yeah, so maybe we'll try to wrap up here so we can discuss more about the general context and your program in Peru, and get to hear more from your colleagues also. So, so I guess as a segue into that discussion and to finish up the case, in a setting where resources might be more limited, how would you prioritize these tests? I can tell you in places I've worked where it sounds like resources are even more limited than in Peru, or similarly low resource to maybe rural areas of Peru, but different from where you're practicing. If you can't get imaging, and if there's not really an easy way to get CSF testing, or you don't have access to the gene expert, which is very sensitive and specific PCR-based testing for TB, or it's you don't have the reagents or what have you. We, in many instances, if the patient is HIV negative and has a chronic meningitis, although it's a long treatment, would say probably we should treat this patient for TB even without being able to prove it. How do you prioritize, you and your colleagues prioritize when this may have costs for the patient or may take time and the patient is ill? What tests would you get sort of in what order? I agree with you, an HIV test is a huge branch point in this case. MRI, probably, although if the patient's meningeal, no papilledema, and you got a CT and it was normal, you'd be comfortable doing a lumbar puncture, which might give you more useful data than the MRI given the choice. But I'm asking you the question that I'm guessing what your answers would be. So why don't you tell us how you would prioritize sort of what stepwise, or from doing all these rotations in the US, everything we listed would just all get done at once and we'd see what comes back, right? But how would you prioritize these things in the context where you work?
Yes, so I had the opportunity in my last year to rotate in 2 different hospitals that have a very big difference in the availability of resources. So in the hospital that I first went to, which is like a national center, everything's almost like the US in terms of access. MRI is still hard to get. It takes a few days to do it, but we can just like do a full scoop. And that was the case in this situation. However, in the other hospital I went to, which is the one I'll use for an example of what's the more usual situation in Peru, we would go using some less sensitive steps. So we would first get, of course, an LP, but instead of taking it to gene expert, which may take a while, we usually do the ADA. I'm not sure, adenosine deaminase. So that would be a first indicator, and then we will wait for a couple of weeks until the gene expert gets back. And we would also do BK on PL and on LP, I'm sorry. And then following that, if that comes up negative, we would, and also the HIV test is, that is readily accessible. Those will be the first 2 things. And then if it comes back negative, we will go with the rest of the scan, like asking for India ink stain and for brucellosis, serology testing, and the whole ANA for autoinflammatory diseases and stuff like that.
Got it. I want to call on Nagali, who had her hand up. Yeah.
Yeah.
Yeah, well, what I've been seeing in this week that I have been rotating in the hospital is that first is the clinical presentation of a patient. And depending on that, then you see if it could be related or not to an infectious problem or tuberculosis directly. But what I've also seen is that, and what I've been told, because I'm in a class where we were taught medicine virtually, and what we were told is that every patient that goes into hospital here in Peru must be taking a thorax radiography before entering to emergencies or like that. I've been in emergency here and I haven't seen that yet, at least. But what I've seen is that what is the main point before thinking or asking for a test to diagnose tuberculosis is the clinical presentation. And what we first ask is a sputum test, and then also the radiography.
Yeah,
And
excellent. Thank you. So important points, right? Where TB is so endemic, right? Even before a patient comes into the hospital, we want to make sure they might not be infecting other patients, right? Great. And then just one quick, in the spirit of global VMR, how do you say India Inc. in Spanish, Marco? And I'll tell you why I'm asking.
It's actually China Inc. in Spanish.
It's the same in French. That's why I was asking.
Oh, really? Yeah, that's I when I studied the first step, I was like, what's India Inc.? And then I read it out and it was like, oh, it's China Inc.
So how do you say it in Spanish?
Chinese Inc. or China Inc.
Yeah,
Tinta China.
Tinta China. Yeah, in French it's Encre de Chine, and in English it's India Inc. So I don't know how this ink became from India or from China. Or from whatever. In any case, important to know, it's not very sensitive actually for crypto. It's on the step, it's a buzzword, right, for Cryptococcus, but in real life, the cryptococcal antigen, or CRAG, is much more sensitive. Okay, so what tests did you do, Marco, and what did you find? And if you want to give everything up to what would tell us the final diagnosis, and we'll see where we are, or if we're already there and you want to finish it, that's fine too. I leave to your judgment.
Okay, it's actually like usually in the cases I present, it's a plot twist. So we were 100% sure this was TB. There was a chronic meningitis, some focal signs that would show us into like there maybe like a POTS disease that was compressing the spinal cord, and that could cause the reflection, the weakness. We were extremely certain about it, but then the gene expert came back. Well, first the BK and the ADA came back and they were negative, both. In the LP and also like BK and sputum, so I was negative. Then the HIV testing was negative, and all the other serologists we asked, like ANA and results, they were all negative. So we were kind of left without much else than to go straight with the MRI, and the MRI was the one that revealed the diagnosis, which is a curious presentation of another disease. So would you like me to jump into
why don't you pause there? Are you going to show us the MRI? No, probably not, from a rest stop in Wichita.
No, I do have the PowerPoint here.
Oh, wow. Okay. So yeah, I guess just to say, as we said, the approach here would be TB, but not everybody has TB, even but that's Bayesian reasoning, right? And then I don't know much about brucellosis. I know it can do something in the spine and endemic areas, but I think you said the serologies were negative. I don't know how sensitive they are. This still seems like a chronic meningitis, and this would then become a very hard diagnosis to make really anywhere, probably, unless there's some particular finding on MRI Marco is going to show us. And what we might start to ask, one is, are we missing an infection? And the sort of most modern advanced technique we can use is called metagenomic next generation sequencing, which is a very cool technique developed by Mike Wilson and colleagues at UC San Francisco. And you can send them their patient's CSF now, and they run what's called agnostic unbiased testing. So instead of saying, I want to test for Cryptococcus, I want to test for adenovirus, they look for any fragment of DNA, RNA that gets matched to a huge sort of biolibrary to see if anything lines up. And they have some case series now. They have diagnosed some extraordinary infections that are very unexpected and that nobody has even heard of. We had a memorable case of a rapidly progressive dementia in Boston. We couldn't find anything. And one of our residents knew that this was happening on a research level and sent the CSF, and it came back as Jamestown Canyon virus encephalitis. None of us had ever heard of it, but they can, because they have the DNA, RNA fingerprints, and they're looking for very small fragments of this stuff in the CSF. I'm not doing justice to the complexity of the technique, but that's my crude understanding. They have these series where they've diagnosed Listeria meningitis, or was it Legionella or Listeria, something very sort of rare or rarer bacteria, fungi, viruses, parasites in patients who had been carrying a diagnosis of sarcoid or other things. So something cool to think about. And Mike Wilson's very responsive on email and very eager to help solve these complicated cases. So wherever you are in the world, if you can find a way to get CSF to him, he can run some fascinating diagnostics on it. So, but you told us the MRI is going to have the answer. And so maybe if we've ruled out infection in this case, does this patient also fit in the time course, as we said, for an inflammatory meningitis, and what types of things can cause inflammatory meningitis? We haven't heard about the eyes being affected. What is it? Vogt, Harayaga, Kanyadi, Vogt, Kanyagi, Harada. It's some very rare sort of eye-brain inflammatory disease. Does patient have one of the recently described antibodies, the GFAP, anti-GFAP protein, which I think can cause a meningitis, and a very characteristic MRI finding of these sort of radially oriented, enhancing kind of perivenular lines coming out from the ventricles. I haven't seen a case of this yet, but called anti-GFAP glial fibrillar, acidic glial fibrillar something, a protein, I think acidic protein. So in this case, if the MRI makes the diagnosis of a meningitis clear, we're seeing more than just inflamed meninges here. Sarcoidosis can cause a meningitis and can cause it isolated from other systemic findings of sarcoid, although we haven't heard about the chest x-ray. Maybe there's some hilar adenopathy Marco has withheld, but really this could be anything infectious that we might not be able to find, or if we made a diagnosis on the MRI, I guess I'm going to lean towards inflammatory. And then I guess the last category we almost never think about is sort of chemical meningitis. Does this patient have a ruptured colloid cyst or a colloid cyst that's been kind of bouncing in and out in the ventricle system, causing these headaches when it obstructs? Though usually those patients will lose consciousness. And then ruptured and cause a chemical meningitis. There's some other tumors that can do that as well. Okay, Marco, what did you find on the MRI?
Well, that's amazing that there are so many differential for meningitis. I think I couldn't name that with a gun pointed at me, but so what the MRI showed us was on the brain, the MRI showed meningeal inflammation, generalized meningeal inflammation, so there was nothing there. But the spine MRI, which I guess I could show, but I'm not sure. Would you like me to show it?
Sure.
Okay. Okay. Yes. Then let me do this. There you go. So this is the cervical spine MRI, and this is the lumbar spine MRI, which I think is the most important one.
And just speaking of global VMR, let's just acknowledge that Marco is sharing MRI scans from Peru from a rest stop in Wichita, Kansas. I don't think it gets more global.
And it's a photograph of the picture. It's not even uploaded from like a CD. It's just a picture of the picture.
So we're seeing the lumbar spine here, and this, oh, you can't see my arrow, but the trapezoidal looking vertebrae. It's sort of the beginning of where it starts to look like a tail. That's S1, so we can count backwards from there, L5, L4, L3, L2, and between L1 and L2, it looks like there's a mass of some sort in the cauda equina. And so what is that? I think it would be very hard to know radiologically. It looks like it's enhancing. So I am squinting at it. I don't know what that is. Could you get a neurocysticercosis cyst down there? I suppose you could. Could you get some type of neurofibroma there on one of the cauda equina roots? I suppose you could. And so was Marco always has a twist, as he said, with the meningeal signs here, not meningeal signs, but signs of irritation of the nerve roots. He did tell us the Lassague sign, which we sort of folded in with the Koenig sign. Is that actually, but no, we heard that there's a headache and meningeal signs as well. So how would this be causing a headache unless it was very large and obstructing CSF outflow? But then presumably we'd have seen hydrocephalus, other signs of elevated intracranial pressure. So there's a meningeal process and some type of deposit here. I can't say I can take it any further, Marco. So I guess you would either wait for some lab to come back that would give you the clue, or maybe you would even consider taking a biopsy of this lesion. But I don't know what that is. Teach us, Marco.
So yes, I did withheld a little bit of information. I withheld the fundus examination. It did show bilateral papilledema. So that was something I withheld just for the fun of it, because I wanted to hear the whole differential. So we did took a biopsy, and the biopsy showed us an intraepidural intratracheal malignant melanoma, which was positive for the whole immunohistochemistry. So yeah, it was really surprising to us, but there was like a clinical clue that one of my I'm sorry, how do I stop sharing? That one of my teachers said, which was the fact that this patient that comes from the highlands was on an increased risk of acral melanoma, which is usually not seen because it comes from, it appears in the legs and it's very distal, and it doesn't grow usually like this, but it grows deeper. And it's very common on patients from his specific ethnic group, which is like native Peruvians, and especially if they have lived in the highlands, which is very exposed to the sun. So yeah, it was pretty sneaky. Then we obtained a dermatology consult, and sure enough, they found the nevus in both legs that we hadn't actually. Yeah, so it was a derm case, but it was dressed up as a neurology case.
And did he have deposits of melanoma in the meninges of the brain as well? Was that the assumption? Or
Yeah, so there were some small nodules described in the MRI. I actually couldn't find them when I was looking at them, but they were described as small nodules in the meninges. So that was the reason for his presentation as a chronic meningitis. He was actually with us for like 3 weeks, and we even thought that it was Guillain-Barré or something like that. There, he's received IVIG. There, it was a whole thing. But I'm summarizing it into like the straightforward approach.
wow. So one thing we didn't mention actually at all, and probably framing bias here, was malignancy as a cause of chronic meningitis, because it's not really a cause of chronic meningitis, but involves the meninges. Well, actually, I should revise that. But when we have metastases to the leptomeninges, the pia and arachnoid in the brain, or of the roots of the peripheral nervous system, we call that carcinomatous meningitis or leptomeningeal metastases. And I guess I would say in this young, healthy patient, right? I wouldn't have been thinking of malignancy. We've been thinking infection, inflammation. We thought about toxic. We got close to tumor, right? Saying about tumors that can spill toxic fluid like a colloid cyst. I guess not a tumor, but sort of a tumor neoplastic lesion or cystic lesion. So one more thing on the differential, right? That we didn't list, that if we were being objective and just saying a schema for things that can affect the meninges, that there would be potential for metastases there. But, and actually we had a recent VMR that we podcasted of leptomeningeal metastases, and that was a patient with cancer and with headache, where then sort of number one on the list was not TB, but cancer metastasized to the meninges. Well, extraordinary case and impressive diagnostic persistence, Marco and his team. And I think the clues here would have been, right, seeing that lesion on the scan, which we of course withhold for the purposes of the VMR discussion, and then deciding that this doesn't look like anything specific. We'd need a piece to know what it is. And rarely this does happen, where you find melanoma somewhere and realize that now you have to go look at the skin, and you never saw that on the skin. Though even if you found a melanoma, you would have to ask yourself, is this also melanoma? Because it's such an atypical place for it to go. Brain mets, sure, but the meningeal melanomatosis is relatively uncommon. Okay, well, I should have guessed from the beginning, Marco, because every case you presented to me has had a very surprising diagnosis, in the spirit of Marco's VMR cases, to say, if it's anything that's obvious to me, I should discard, and I should be digging deeper to think about rare things. Well, let's turn it back to, so thank you for bringing this case. We've all learned from it. I hope you'll be writing this case up, because there's a lot to learn from it. Let me turn it back to Maria so we can talk more about things beyond meningeal melanomatosis.
Oh my God, what
Thank
a
you, guys.
case, Marco. Thank you so much for coming, everyone, and presenting this case. Now we're going to transition to the part of the Q&A. I know that Nayeli told me that Angela was also here. We like to start very light, but very important, with like the most important thing to all of us, which is food. So Nayeli, I don't know if you or Angela might want to answer. If we come to Peru, what should we eat? Like, what things do we need to eat?
Well, first, if you come to Lima, I first will suggest ceviche, pollo a la brasa, things like that, like from the coast.
That's awesome.
Hi, how are you? I am Angela. Well, I am studying with Nayeli. She invited me here, and thank you. Was a great case. Now I'm very surprised, because I think another things, but melanoma, I didn't expect that.
Thank you so much for sharing all of these. And I think, I struggle with food and knowing a little bit about like infectious disease, and especially neuroinfectious. Erin, how can you eat anything knowing so much? Like, how, like, now that we know about all of these rare parasites, I don't know if I can eat ceviche in Peru. No, of course I can, because if you don't do something that scares a neuroinfectious specialist once a day, you're not living the right way.
I think there's a question in the chat, Maria.
Ooh, and Rosa, do you want to open up your mic and ask that question? We can also read it if you're not available, but you can introduce yourself and ask it out loud.
Sorry. Hello. Oh, hi. Hi, I'm Ana Rosa. I'm an aspiring medical student, and my question is, what's something that you've noticed is really different with diagnosis, if any, in Peru rather than the US, let's say? Thank you very much.
Thank you. And Marco, do you want to go ahead?
Yes. Well, first of all, I guess it's the limited resources, as Najali said, that makes a big emphasis, that puts a big emphasis on clinical diagnosis. And also the fact that, as Aaron said, most of our patients present on later stages of diseases. So that makes some clinical signs more sensitive. And our diagnosis is more dependent on clinical findings rather than laboratory and imaging, which is less easy to obtain. I guess the second thing would be the prevalence of infectious diseases, which is not that high in the US. Well, it is really, really high in Peru. And I think that the last thing would be sometimes the language barriers or the cultural barriers with different ethnic groups in Peru, as we have various groups. And even if the predominant language is Spanish, not everyone in the country feels comfortable with that, or not everyone is used to the way of treating medicine as we do it, like in Lima instead of in other places of Peru. So I think there are a lot of nuances there. It's a less uniform country than the US, I think. So that also gives some questions when you're trying to communicate with the patient. So I think those are the main differences.
Thank you so much. Sorry, I just want to say a huge thanks. That was very interesting. Thank you.
Thank you, Ana Rosa. And if you have anybody else has questions, you can put them in the chat. And Marco, I'm so glad that you mentioned, the differences in. Ooh, somebody. No, I'm sorry. The differences in the population you treat and how everybody, they speak different languages. They come from different parts of your country. They eat different foods. They have different traditions. And I've been trying to read a lot about, the explanatory models of disease, because now I'm also working in a rural area in Guatemala, and I've noticed that I tend to have very few patients with neurological complaints. So I started asking, like, when you have something neurological and we have like different words for it, who do you go to, and people from Guatemala and from the indigenous areas in Guatemala, they rarely go to a doctor first. They try more traditional medicine and indigenous medicine. Do you have something along that experience in Peru, or can you tell us a couple of stories? I don't know who wants to take this question.
Well, yeah, that's definitely the case. That's actually, I think the majority of people in Peru don't come to the doctor first. If you are outside the big cities like Lima, the first, I don't know how you call it in the US, but the direct translation will be like kind of like bone turner. So it's someone that it's kind of like a chiropractor, but he's more like a spiritual chiropractor. So that's most of. They also, like, there's some local treatments where they will pass eggs around the body, or they will take a live guinea pig and they will scrub it all along, so it grabs the disease, and then he will become black. That's how you get that he actually cured you, because he becomes like he darkens in color. The same with the eggs. So yeah, it's that's usually the way. The first line of treatment. Yeah. And while in the city, it's they also don't come to a doctor first. They will go to a pharmacist first, and he sometimes prescribes stuff, and they may never get to the actual hospital and stuff. Yeah, it's there are a lot of flaws in how our healthcare is run, but yeah.
No, I was saying that that is so interesting because even though, in Guatemala, we have around like 23 different ethnic groups and most of them are indigenous, but they're very different from the indigenous groups in Peru. But that is interesting about the egg that you mentioned. That is something that it's also practiced here. Now I'll have to go dig deeper into that. But yeah, I see that a lot of people are mentioning that these things happen all around the world, and I think it's something that we tend to see it in Western medicine as a failure of our health systems and things like that. But it's also the importance of cultural competency and treating the person in what's right for them and what they've grown up with. Nayeli, I don't know if you want to mention something else.
Yes, I think that there is another problem related to that with the treatment, because many people here go and treat themselves with what they think they should be treated for, or with medicines that they think are correctly. For example, there are many people that use corticoids for many problems, and then at the end they will be worse and they will like have more diseases, more problems. And also with infections, they treat themselves with antibiotics, and at the end they will increase that resistance. And that's what I've seen just yesterday. There is a woman that has like many resistances to many firms, and it was because she used many years different antibiotics for her urinary infections.
Yeah, I think that you're so right about that. And I think that it's also something that a lot of people in the chat will be able to relate to. There's this huge burden of disease, and there's very few doctors, especially like very few neurologists, and especially like very few specialized neurologists all over the world. So there's a lot of people like filling in the gaps that might not have that knowledge, such as Marco said, pharmacists and community nurses. You're really the ones that have more contact with these patients at first. So I think you're totally right about that. And it's also, an opportunity for us to, work in more diverse teams. And I know that the first time I met Marco was actually through Kara, because I'm very interested in indigenous languages and also in neurology. And I know that Marco was working with your group in a very interesting and unique project with Quechua languages. I don't know if Marco or Nayeli or Angela, do you want to tell us a little bit more about what we did?
Yeah, so that's a project that we were working with Dr. Custodio, who is a leading researcher in dementia in Peru, and it comes from the experience we had when working at a hospital that is it's a urban hospital, but it's a bit more peripheral than the one that I was. That was a national referral, and most patients we had immigrated from the highlands, and the younger ones would speak Spanish very well, but the older ones seem to have a bit of trouble with it. And all of our healthcare system is designed in Spanish. And so when these patients were evaluated for cognitive disorders, for example, they would be tested using Spanish brief cognitive tests, like the MMSE test, which has been officially translated to Spanish, but not to any of the indigenous language. And these patients would consistently get lower rates than those in Spanish, not because they had cognitive impairment, but because they just had trouble with the language because it was not their native language. And so what we decided to do, we first did like a whole literature review, and we found out that all of these patients whose native language was not Spanish had been excluded from major studies in dementia in the country, because one of the exclusion criteria was Spanish will be your native language. And then what we also looked was that patients who are at risk of dementia, which are elderly patients, in Peru, around 60% of them do not speak Spanish as a first language. Out of those, the majority speak Quechua, which is the Inca traditional language instead of Spanish would be their native language. So what we did is we teamed up with a group of psychologists from Cusco who were native Quechua speakers, and they went into rural towns in Cusco and administered the test, just a translated test that we work with linguists and stuff to adapt the rudest brief cognitive test, which is a test especially designed for patients with low educational backgrounds. And so we translated that with linguists, and then we use the help of the psychologist to administer that test in these rural towns and validate like the first draft of it. So we are just there. We just finished, well, a few months ago, we actually finished the draft. We presented the findings in an abstract for the AN Congress, and it showed that the adaptive test was good. It was understood. Patient described it as how do you say it? That it was straightforward, because some of the questions in the test require some environmental cues, like for example, what could you describe to me what you would do if there was like if the road in the traffic sign became red? So how do you translate that to a rural area of someone who doesn't speak Spanish and usually does not interact that much with vehicles and stuff? So we using the help, we transformed that to like the passing of cattle, and that helped a lot, and people were able to understand it, and we obtained really good measurements with that. So now the next plan is, if we obtain funding, which is the plan, to roll it out in a bigger scale, to enroll 500 or 600 patients and be able to actually test if it's good in diagnosing as a brief cognitive test for dementia. So yeah, that's the plan.
That is so impressive. Congratulations, everyone involved in this. I think it's so important what you mentioned about the languages and everything. I have a couple of funny stories that, you know, when I was in med school, one of the questions for the Minimental test is, you know, what season is there? Or like, what season are we in right now? And Guatemala is known to be the land of eternal spring. That is literally our slogan. So we don't really have seasons here. So whenever I went to like ask these questions, people would say like harvest season. And I was like, well, that's not a season, but I'll count it because people are harvesting right now. Or they'd mention things like Cuaresma, like the religion traditions. So they'd mention it's Cuaresma season. And I'm like, okay, that's not what I was expecting, but I'll count it as right, because I think they're getting, you know, I think they're getting some answers right. Just the questions are the ones that are wrong. So I think that is super important. I love the changes in not only language, but you know, the cultural competency of these tools. When I was in Spain, we used to ask, you know, how many vegetables can you mention in a minute, right? And they'd mention things like peas. And when I asked the question in Spanish, I never once got peas. We don't grow peas here, and people don't eat peas. And I thought it was so interesting. You know, now whenever I examine somebody and I always ask vegetables, I always make like a mental note of like, this vegetable grows here. So I think I can't wait to read more about it. I'm very impressed by your work, and it's definitely going to impact the life of a lot of people in your country. I know that, Pranati, I don't know if you can open up your mic, but I think you have a really interesting question. I don't know if you want to say it yourself, or can I read it?
Yes, hi. I had a question about access to medications for people in underserved areas who may not, you know, have the resources or the finances to get medication easily. How is that, how do you kind of, I guess, deal with that in the hospital setting? Because I know in underserved areas, like I live close to Detroit, which is a city that's pretty underserved, and there are patients that, you know, come in and they say that they haven't been taking their insulin shots in 3 weeks because they haven't, you know, they weren't able to pay for it or something like that. And so are there are there situations like that in Peru in underserved areas where patients aren't compliant because they don't have the resources to access medication?
Should I take that one? I guess so. Well, we do have a program in the country which serves most of the population. 60% of the population does not have any type of insurance. It's a very complex issue, but I love that topic. But I'll wrap it up very quickly. So we have three types of insurance in the country. There is national insurance, which is universal. There is employment-based insurance, which is just for those employed, and there is private insurance, which it's like 10% of the insurance, which is very expensive, and it's reserved for very wealthy part of the population. They all have troubles, but they are usually, the national insurance is very poorly financed, but it's able to provide at least some care for patients. So the national program for insurance does give complete care for diabetes, for obesity, for preventable diseases, and also for some infections like TB and HIV. It does not cover a lot of things, and it's not perfect at all, but it is kind of a place that they can find care. It is difficult to access. It takes time. It has a lot of issues, but it does provide them some of the medications they require.
Thank you so much, Benetti and Marco, for that question and answer. I have just two more questions, I promise. One is, I have a question specifically for Nayeli. You're doing an amazing job running a research group focused in neurology in Peru. How has it been? What can you tell us about your experience? What have you learned? What challenges do you have?
Okay. Thank you for that question. It has been really challenging because I'm actually preparing for the step 1 for taking it in December. And well, I accepted the lead of Hain because I'm really into investigating, making research, and I have really good mentors. And what interests me the most is that by researching and by discovering new information, you can help many people. Because I felt that it was more related to like the theory, because when I was in my first 3 years, we were made to read a lot of papers, but they were like more focused on theory, learning about infections, learning about clinical science too. But now what I like to do research about is treatments in neurosurgery or treatments in general, so we can see which one is better or which one have less mortality rate, or which one has better rates in curations, and more in pediatrics. That's my interest. So it has been really challenging because it was the first time that I could lead a very big group, and what I've been doing is an innovation, because as my interest it goes for United States, we as Peruvians don't do many investigations, so I decided to give more opportunity to the people here. So we divided the group into one group is for the ones that want to go to United States, so they will just read and do research in English, and the others, which is called LATAM y Resto del Mundo, it's for Latin America and the rest of the world, and they will do research in Spanish, and their focus is more in this part of the world. So we will be more prepared, and we will have more information for when we will finish the career, and we will more focused on that, because it's really important to know, in my opinion, what it's your interest in. I mean, like for residency, because you have to be prepared for that, and so that way you could help more, because the more the younger you are when you start doing research, the more information that you will provide to others. So that's my interest in my main objective in Hain, and my group for leading. It's really, really nice. I have had big support from them. It's we are 3 women in the directing, leading the group. They could not be here for this time because we are having different programs. Some of them are right now at the hospital. Right now I'm here. I'm gonna go to the hospital at night. So, well, that's my experience to the moment, and I hope that I will be a better one leading Hein, and I would like to know more about this program for clinical cases so I can see what I can do more research about too. Thank you.
Thank you, Nayeli. I think you inspired a lot of people. I know it's really hard. It's really hard, being a med student in a country with few resources, being a clinician, providing the care that your patients need. And on top of that, doing research, is another step that, you have a lot of barriers, but it sounds that like you are doing all of the right, like you're taking all of the right steps and moving in the right direction. It is possible to create research in a country outside of the US and publish outside of the US. And I think it's amazing how you've divided it. Capacity building is something that people don't focus a lot in when they do research and when they do global training. And I think it's the most important thing that we have to do, capacity building. So it sounds I'll keep an eye on your organization forever, because I think you're producing very interesting papers, and the way that you're doing it is really, really interesting. So I want to thank everyone.
Thank you very much.
Thank you so much, Marco, Nayeli, Angela, for coming. I have news for the IMGs. I know that a lot of you stayed. We are going to have a personal statement workshop. This is going to be exclusive, well, not exclusive, but this is going to be dedicated for non-US IMGs that are trying to get into the US for this match season. We're going to have a conference that's going to be available for everyone, but the really special thing that we're doing is that we're going to have 30 spaces for 30 people to have one-on-one mentoring for their personal statement. I'm going to leave the link here. We're going to try to have as much people as possible. I didn't share it. I'm sorry. We're gonna try to help as much of you guys out writing your personal statement. Unfortunately, spaces are limited, so we've reserved a couple of special spaces for the people who joined today. So yeah, that was the news. Thank you everyone for coming. Marco, Nayeli, Angela, Kiara, my Peruvian friends, Erin for facilitating, and everyone else with their questions and enthusiasm for global clinical reasoning. I don't know if anybody wants to say bye as well.
I want to thank you, Maria, for organizing these extraordinary sessions. And if you haven't seen the incredible scope and breadth and reach of Maria's work, check out the graphic on the CP Solvers website with the map of the world and how many countries we've had global VMRs from to learn from each other, as we were able to do this morning, thanks to Maria and her team's efforts. So glad we got to meet some new colleagues from Peru and see some of our other colleagues from Peru, even if they're in Wichita, Kansas at the moment. And I think that makes 3 cases Marco or 4 cases he's presented to me, and I've never been able to get the answer, which is my favorite kind of case, because then you expand what you should be thinking about when you see a complicated case. So thanks, Marco, and thanks, Nayeli and Kiara and your colleagues from Peru from joining us today. And thanks again, Maria, for this incredible initiative and for making one more neurology one so I could join.
Yay, we'll keep doing these. So thank you so much. Hope everyone has a nice weekend. Hope Marco gets safe to Kansas.
Thank you guys. Yeah, I'll send you a message. Bye. My battery lasted enough. Thank you so much for your time.
Thanks again. Bye.
Bye. Thank you. Gracias.
Muchas gracias.